This episode is being brought to you by my good friends over at McLaren and Associates. McLaren and Associates is the premier sell-side advisory firm for dental practice owners seeking a DSO affiliation or private equity partnership. Their team is comprised of experienced sell-side advisors whose sole focus is to educate practice owners regarding their EBITDA and practice value, then create a highly competitive environment among multiple DSO buyers to create multiple options to maximize your outcome from the sale. If you're interested in learning more about DSO transactions and the options available in today's marketplace, reach out to Brannon Moncrief at McLaren and Associates at 512-660-8505 or go to dentaltransitions.com. That's 512-660-8505 or go to dentaltransitions.com. This is one of the biggest decisions in a practice owner's journey, so make sure you're working with the best. McLaren and Associates.
The Dentalpreneur Podcast. Okay, doctor, it's time to put down that handpiece. You're listening to the show dedicated to helping dentists get their lives back. It's time to decrease your stress, increase your profitability, and regain your passion. Now introducing your host, Dr. Mark Costas.
Hello, everyone. Welcome to another episode of the Dentalpreneur Podcast. I'm your host, Dr. Mark Costas. What's up, friends? All right. This is a Surgical Saturday episode. If you guys are listening to this and it's not a Saturday, that's cool. Most people don't listen to them on the actual day that we post them. But this is surgically based. And in this case, this is all about prosthetic conversion. So as always, we're featuring Dr. Dan Brisky and Dr. Taher Dune. This was a live webinar that we had inside of the Dental Success Network, and I'm turning it into a podcast for all you fine folks that listen to the podcast on the regular. So if you're looking for practice management tips, if you're looking for personal development, this may not be the episode for you, but if you're into prosthetics, if you're into advanced clinical procedures, if you're into surgery, this is right up your alley. The Surgical Saturdays are right up your alley. Once again, this is all about advanced prosthetics and prosthetic conversion. We talk about the analog approach. We talk about the different steps to hybrid and removable when it comes to actually restoring the implants that we're placing and the digital workflow as well. So I hope you guys get a ton of value. As always, Dan Brisky and Taher Dune are just a wealth of knowledge, and they're so generous and patient with the way that they teach, passing on that knowledge and information to anybody that is seeking it is just one of our core values inside the dental success companies. But these guys are just, as good as it gets. And I have the really huge privilege of being able to work with them on the regular in Greeley, Colorado at the Colorado Surgical Institute, looking over their shoulders and watching the miraculous things they're able to do with a scalpel and an implant and all things advanced surgical, but they're just as good at the prosthetic portion of the procedure as well. So you guys let me know what you think. I hope you get a ton of value from this Surgical Saturday. And we'll talk to you soon. Take care. Bye-bye. Hello, DSN. What's up, everybody? I hope you're all doing great today. Thank you for joining us live for what we would call a Surgical Saturday. That's the way it's going to appear on the podcast. But we have our surgical studs, our in-house surgical studs, Dr. Taher Dune and Dr. Dan Brisky with us. And today we're going to be talking about immediate loading of and prosthetic conversion, which is something that we come across often while at CSI. People are very, very interested in the next step after placing the implants and what to do as far as immediate load and prosthetics in general. We had a really nice discussion last week about prosthetics and the All-on-X procedure and onesies and twosies, implants, etc. Today, we're going to talk about immediate loading. So welcome to the webinar, Dr. Taher Dune and Dr. Dan Brisky. What's up, fellas?
Not too much, man. We're having an all-day CSI kind of like a just an event, catching up on things, plans for next year. So a lot of different creative type of strategy conversations occurring today.
Oh, very nice. Cool. So you're just taking the time to hop on camera for a little bit in the middle of your admin day. That's great. It's good to see you guys both like sitting next to each other and not on two different screens, as we usually do. Oh, wow. Look, they actually know each other. It's you guys are fond of one another. I see, or at least pretending very well. Cool. So, I don't know who's going to take the lead, in the webinar, but, I see that you guys have a beautiful, PowerPoint presentation that we're going to click through, and whoever wants to take the lead, we can go ahead. And then the other two panelists will most definitely have questions and information to add as we go along here.
Cool. So Dr. Brooksy is going to be the quarterback.
Sweet.
So I'm going to kind of give an overview of a few things like analog, prosthetic conversions, hybrid, which means you maybe own some of the pieces, which maybe you don't own all the pieces yet, and which pieces you should buy. And then how to go fully digital eventually, right? Because we can't all afford to buy an iCam and a printer and a scanner and all of these things in our practices, right? But maybe we can add a piece a year or a piece every 2 years and eventually get there.
And what I would say on that also is sometimes, even if you do have the money to buy it all right now, with how technology is changing so quickly, there's some things that you might want to buy in this moment that you should just wait 6 months on, and you can save a whole lot of money too. So we'll kind of talk about the strategic ways to add these procedures and equipment and different things to the practice also.
Yeah. I'd say at least 90% of offices will still do denture workflow, right? There's nothing wrong with it. It's just once you change from this technique, you tend to not want to go back. Your nightmares tend to stop, and you start having real dreams about vacations instead.
Yeah, the prosthetics is the hardest part. Once you get the surgery down, it's actually like the easiest part of my day, and it's dealing with all the prosthetics afterwards that becomes more complex.
Interesting.
So we're going to do fabrication of a denture pre-surgery, and this denture needs to be at like a correct vertical dimension. So we talk about that a lot, where you need to grab a VDO gauge, open up the patient's bite, and then fabricate a denture around that increased VDO. That way, when your patient doesn't have some tiny looking teeth and very narrow arch and very thin prosthetic. So I think definitely making a denture is not always easy. But I wish dental school would have taught us how to make a denture better.
Yeah.
So unfortunately, they didn't.
So all the concepts hold true with like how to fabricate a denture. It's you got to check the VDO from the corner of the eye to the corner of the mouth. And then these VDO gauges, we can actually make a post and like show you where to get it. We just get it from like eBay or anywhere. But you measure from the corner of the eye to the corner of the mouth, and then it'll rotate around and it'll measure from the chin to the nose. And those measurements will be very close to the same. And you'll know if you have to open or close the patient. And then you have to use a leaf gauge or something to get your digital records or your bite records in a centric relation bite. And it makes the conversion process so much easier. When you implement this one simple step that costs like an extra $100 to implement, you're going to have a lot of money saved on the back end, and you're going to have less of those cases that come in where they have an anterior open bite. Dr. Costas, I'm sure you delivered a denture and then had them come back in a week later and they have an anterior open bite, and it's because the condyle seats, and that's because we didn't get the records in a centric relation type of situation.
That's never happened to me ever. Never ever happened to me. I will just ask just a clarifying question just to make sure that everybody's on the same page here. Do you guys find it ideal if the patient is not a dentulist to fabricate an immediate style denture prior to surgery, or are you waiting till the patient is edentulated and then fabricating the denture that way? What's your preference?
So even using digital wise, I still make a denture. I recommend it, or at least print a denture, because you need to start from somewhere in terms of where the teeth are, where the midline is, how far the open VDO is. Okay. So I would definitely recommend still making a denture if the patient comes into dentals.
Yeah, and I'll take that a step further and say, if there's natural teeth at all, even if it's like a partial dentition case, but there's occlusion that keeps the VDO in a proper place that you can go reproducible, it's far easier that way than a completely edentulous case. where the dentures are worn down and all of the above. So I'd like to have tooth-borne stops if I can. It just helps in the digital records and fabrication process. And that's my personal preference, but sometimes you're going to get edentulous cases. And then you have to fabricate your denture and go through the steps to really ensure a good result.
Cool. Thanks for clarifying, guys.
Yeah, there's some little things too that we show our students as well, like how to get like a squish bite, like a quick bite to a fabricated denture. Sometimes you actually don't have to, or you can make a bite rim that sometimes can subsidize from making a denture also. But we don't really recommend doing that off the bat. I'd say make a denture first so you can see it.
Cool.
So when we used to do the dental workflows, what we did was I used to apply like a bite registration, like the blue bite or the green bite over the intaglio of the denture. Then I placed it over the MUA, just as a ballpark position of kind of where I am. Then when I'm picking up implants, you can either cut separate holes through the prosthetic where each MUA is located, which tends to be very difficult, or you can cut a slot from the most distal implant to the other most distal implant and just make entire slots where everything can just kind of go over the top. I found that to be a little bit easier over the years.
Yeah, and I do that, but now I have my lab pre-designed the denture with the slot pre-designed in it. So when it 3D prints, that slot that goes in a horseshoe fashion over the intaglio component is already in there, so I don't have to cut it open further. A lot of labs will make that line or that slot too thin, tell them to open it up a little bit. So that way you can visualize things really clearly when you have your implants placed.
Mm-hmm. And for temporary cylinders, they make tall ones and short ones. I'd say for the most part, I'll use the tall ones. Sometimes you'll have to use a shorter one, or you'll take the tall tie base and you'll cut off like 2 or 3 millimeters of it to make it seat a little bit better. I will sandblast the temp cylinders as well, so it's a little bit easier to bond to. Nothing is more annoying when you go to put the cement around the tie bases or the temp cylinders, and then it just comes off and it doesn't get picked up in the impression. That's always really frustrating. So I always recommend sandblasting the temp cylinder.
Cool. Good tip.
So we make like a horseshoe size rubber dam and I place that over the temporary cylinders after you put them on and after you sandblast them, all of that. Then I plug the tip of the temporary cylinders with usually just Teflon. A lot of people use PVS, which isn't wrong. I just think there's less expensive things you can put inside the hole.
Yeah. One tip I just want to add real quick is before you put your rubber dam on, make sure you get really good hemostasis. Whether you have to use Lido 1 to 50 or you got to, compress the tissue, you can soak a 4x4 in Lido 1 to 50. So you have like basically hemostatic 4x4s and you can squeeze the tissue down. What you're going to do is you're cleaning the site, but you're also controlling the bleeding. You have good suturing, but the less blood that comes outside of that rubber dam, the more likely is your denture is going to bond and cure better when you do your pickup. And then 2, with your temp cylinders and your Teflon, we'll take the Teflon and we'll pre-roll it out into like a nice cone type of shape. And we just cut it and we just have a container filled with pre-rolled Teflon. So that way it's just easily, used and you're not sitting there just packing Teflon in. It's all pre-rolled and it fits in those temp cylinders perfectly.
Mm-hmm. We've tried pretty much every material out there to inject around the denture. And I've found the ProBase ProBase cold liquid acrylic is the best one. And you tend to need a lot of this material. So you'll mix it up, then you'll put it in a monojet syringe and then you'll put that behind you and you're going to be squirting that around each temporary cylinder.
And sometimes you can cut the tip off the monojet syringe to make the diameter of the opening bigger. So that way you can express it more quickly. If you're feeling a lot of like pressure and pushback, or you don't have as strong of hands as Dr. Brisky, you can cut it to make that exit point of the ProBase or the material come out a little easier for you.
Yeah, and then do like a rehearsal. So I'll put the denture in and mock kind of closing the patient. And sometimes what you'll find is a temporary cylinder might be really too tall. So I'll keep tie bases, but I'll also keep tie bases that have like 2 or 3 millimeters cut off on it. Then I would switch those out. So that way, when you close the patient, you close them into a pretty good occlusion. And then rather than, you finish the process and the whole thing is so canted. You're like, oh my God, what do I do? This patient just paid $25,000 for this. And then they're walking out with a really crooked smile. And then your picture ends up on Facebook, right? So after you put the cold liquid acrylic around each one, you hold it into place. Then you will remove, after you kind of that, you'll remove any cylinders that are not stable after it cures. It's very frustrating when that happens. I kind of close my eyes when I take it off. And then when I take it off, I just kind of peek at it. Then I'm either, I might have a few cuss words or I will not have a few cuss words at that time. So you need to be very, very passive. So anything that's not passive, you're going to be repicking up. What I found also is to grab one of those lab analogs, which is, it's basically a replica of an MUA. And you can screw that into the temp cylinder, and then you can squirt the rest of the acrylic around the temp cylinder. So that way you're not getting it locked in, into the MUA position. So it's a little bit easier.
And so, if you haven't done this before, that's kind of hard to envision sometimes. So also feel free to reach out to us, because this procedure per patient is so nuanced and so technical, especially when you're doing it in this fashion, that sometimes like reaching out to someone who's done it a bunch before can really help demystify it. So we definitely encourage you guys to message us on DSN or message us through social. And we're more than happy to hop on a phone call and kind of walk you through the case. What we want you to do is take pictures of things, send it to us so we can kind of visualize the case with you and then talk you through the steps also.
Yeah. So after it's all there, you're gonna start polishing and cutting distal flanges. I see a lot of docs who overextend the distal flange too much. So I'd say if it's an all-on-4 and your implant comes out at the second premolar, then I would only have one molar on your denture. If let's say you do an all-on-4 and your emergent comes out at the first premolar, then I would just do it up to a second premolar. Because the last thing you want is for a patient to bite down and break the temporary. Then you have to remake this whole process. It's one of the most annoying things ever. So don't overextend distal flanges so the patient doesn't break them. So that way you have significantly less lab bills to deal with.
Is there a hard, fast rule? Like how many millimeters past the distal, implant are you thinking you should go? Like 1 molar width or 1 premolar width?
Yeah, for me in temporaries, maybe I would do like 1 premolar past the last cylinder.
Okay.
In a temporary, and then in a final, it's like 15 millimeters. You don't really want to extend the zirconia past that. And if you're into FP1 territory, I think it goes down to like 10 or 11 millimeters of a distal extension, because your FP1s are thinner prosthetics for the zirconia thickness.
Yeah, and I actually have printed temps in the consult room right before the patient, when we do their when we sign consents and give prescriptions, I'll actually show them exactly how many teeth they're going to get. Because the last thing I want them to tell me is, hey, how come I don't have these teeth? So I actually have one that has the second molars and one that has first molars, one that has premolars. And I'll show them this one is you. And it comes off pretty confident because I tell them this is where your implants are going. And this is how many teeth you're going to have. So I hate, when I get more questions, it's because I didn't inform the patient myself. So I try to remember of all those things over the years that patients are asking me. And then I try to solve that so that way they don't ask me that. I like to have visits where they don't ask me any questions. Only 1 or 2 small ones because they may have forgotten something small, but the less questions they get, the better.
Yeah, I always find that if you blame it on anatomy or their personal bone structure or whatever, and you explain that in the beginning, then that does not become your fault or the designer's fault or the prosthetics fault. It's actually, this is the limitation of your skeletal structure. I always find that the best way to go.
Yeah. And the only thing I'll add to that is I tell them, hey, if you want these second molars, it's an extra $10,000 for us to do all that additional work to get you 1 extra tooth per side. Is that worth it to you? And then at that point, everyone's like, no, it's not. But you have to say that to your consultation. You can't say that after you deliver the prosthetic.
Yeah, good point. Yeah. Really good point, guys.
Another good way to do things is a smart denture conversion. I've done a few of them, and they work really well. But I don't do them personally because they're expensive still. So all it is it uses a proprietary like fastener piece, and that basically snaps or clicks it, and that goes into the top of it. It's a nice way to do it, and I think it creates a stronger prosthetic because it's going to be a little bit thicker and taller, and not so much room where you're hollowing out the denture and making big holes in it and making it less strong.
Actually, can you go back to the last slide? I forgot one point I want to make.
Yeah.
So basically, when you do your denture conversions, I'll have the lab create a duplicate denture, and I'll actually pick it up twice. Okay, beautiful. Great. We'll get to that then. Yeah.
See, we're on the same page.
Further evidence. I like it.
Yeah, further evidence. Yep. So, you'll basically still just convert a denture to screw. You're converting it to a screw retain, but it's a more accurate screw retained conversion, which is why I like it.
Okay.
But you're doing the same thing where you're applying acrylic and then you're seating the dental prosthesis. After you cure, same thing, you take it off, then you remove the threaded posts from the multi-unit, and then you create a pilot hole through the tie base, and then expand enough for a screw to go through it, which is pretty cool. So that's why I like it, is because you basically can just create a small pilot hole through it, and you're going to be creating a very screw retained but a very strong prosthetic, which is really awesome. It's just a little bit more expensive a way to do it. I still think for these conversions or smart denture conversion, I would still rather pay a lab to do it, because most of these patients, when you're doing these cases and you get, I say average practice may do maybe 2 to 4 of these a year. It's a lot of work to do this conversion process. I'd rather sip on my coffee and maybe pseudo laugh a little bit with the lab tech while they're doing the conversion process, and you can have them swear. It is a little bit of a frustrating process if you don't do it enough.
Mm-hmm.
Yeah, agreed.
Yep.
So through the evolution of getting the bits and pieces, Dr. Dude and I started doing this back in like 2019, where we bought a printer, and we're one of the first people to try to figure this thing out. And we had a lot of annoying conversations. We're like, how come we can't do this? How come we do that? And we just didn't know what to do because we didn't know who to talk to. And we just didn't have many people to really reference or ask questions to. So this is kind of like a lot of like figuring it out. But one thing that we thought of at the time back 4 years ago, we were like, well, why don't we print it, but we'll do a combination of analog and digital techniques so we can convert it after we print it. Right. So then this whole conversation came up of the use of a designer. All right. And some dude who sits on his computer and designs your teeth, and then you print it at home, and then you'll be able to pick up the printed hybrid in your own office, which is really cool.
And so if you want to get into this space, the most cost-effective way is to start with an intraoral scanner and a printer. And you can then print off 3 copies of these hybrids. And you can have pretty accurate data. You still need to use like cement or acrylic to pick up your cylinders, but you don't have to use as much. If you're doing like the old school dentures, it's just so much acrylic, and it leads to so many more hours in the chair that I think if you're using acrylic still with a denture, there's a better way that the investment is absolutely worth it. So this hybrid technique is what I would recommend, is like where everyone consider going from day one. Because it's going to make your life that much easier. Or if you're not ready for that investment, just plan on hiring like a denturist or someone to come in and actually and do the conversions for you. Because if you're not doing it every day, like Dr. Brisky said, it's not worth the headache.
So this like idea of a rapid appliance back in the day, when we did some chrome guided files 4 or 5 years ago, Roe at the time were the most innovative, I'd say, in terms of like these techniques. And they call it a rapid appliance. A rapid appliance is basically just another hybrid. So a second one that you're going to use to reference later down the road.
So the theory behind the hybrid approach is, on your surgical date, you're already doing all the heavy lifting. Let's go ahead and do a little bit more of it on day one. So then 3 months down the road, you're going to save yourself 3 or 4 appointments. And essentially what you're going to do is you're going to pick up one set of teeth for the patient to leave with. You're going to pick up another set of teeth. And this is when you want to be cost effective. Hence the 3D printer is better. But if you want to have your lab create like a cheap duplicate denture and just get the price down, say this is not really serving a purpose other than lab work, so give it to me for as cheap as you can. And you pick up a secondary set of implant locations on the tall temp cylinders. And then inside the tall temp cylinder, you put your analogs that you would typically see a lab put in stone. You put that inside your temp cylinder, and then you set it in stone. So now on the day of your surgery, you just do it in your like quick set stone or anything, or even just conventional stone. You have a implant location registered on that day. So you've already registered your implant location on your surgical day via analog techniques. Then what you can do is you can utilize that in twofold. If it's a duplicated denture and the patient breaks it, well, you got to back up. Great. If it's not, it just sits in the case pan for 3 months out. And then you can use that as a set of your final records. And you got to consider this, your implant location. Okay, we're going to talk about macro scale and micro scale. Macroscopically, those implants don't change location. Mm-hmm. Microscopically, there might be some subtle movements to the implants over the integration period over a couple of months. So you're going to have to re-verify those locations of your implants, whether it's photogrammetry or whether it's old school lab techniques. So what you do is you take this now secondary converted denture and you section it through with one of those ortho discs you use for IPR, or just a really thin burr, like a 1 millimeter burr. Section through it in between each cylinder and then put it in the patient's mouth and then lute it together with a resin that has a very low shrink factor. And so essentially you're re-establishing passivity between the new micro movement of the implants, re-establishing your VDO, re-establishing the patient's desire with cosmetics, getting all your records, taking a new soft tissue impression underneath. So what you'll do is you'll just put, PVS adhesive underneath the prosthetic, put PVS in and then seat it. So now you're capturing a new soft tissue location, and then you can send all of that to your lab. And that's literally saved you 3 appointments. I mean, back in the day, I do a wax rim that was screwed into a couple of implants. Then I do a tooth try-in that was screwed into a couple of implants. Then I would go and send it back to the lab and we tried something else in, and then we go to the final and it still be not as perfect as it should be. This saves you, countless hours in this process of a hybrid approach by doing this rapid pickup appliance technique or whatever you want to call it. But by doing a little bit of extra work on your surgical day, you've saved yourself probably 10 to 12 hours later down the road.
Hey doc, are you overwhelmed, sick of being the bottleneck, not sure where to jump in and tackle projects? The idea of having an assistant may seem like a luxury and something you don't need. However, as practicing clinicians, business owners, husbands, wives, moms, and dads, you may be holding yourself, your business, and even your family back by not delegating day-to-day tasks and maximizing your valuable time. If you guys have heard our podcast and webinars before, you know I hired a personal assistant 8 years ago and haven't looked back. I hired Ashley Evans at the time, now Ashley Hirschfeld, and we were able to execute, prioritize, and launch projects and businesses that have led to multiple streams of income and invaluable peace of mind. Ashley has now founded GSD Queen, where she is helping busy entrepreneurs and business owners find the right personal, virtual, or executive assistant to help you get the momentum you need to reach your goals. With Ashley's assistant program, you get one-on-one consultation with her to create your perfect personal or executive assistant avatar and ad. Execution of placing ads. Review of resumes. Skill and personality testing to narrow down to 2 to 3 candidates. Guidance in maximizing in-person reviews. After selection and hire, the assistant will receive 4 weeks of GSD Queen Bootcamp, where they will learn the tips and tricks to being an efficient and forward-thinking assistant. Reach out to Ashley directly at 928-910-3599 for more details and more information. If you happen to be a DSN member, reach out to Ashley inside Workplace to get a $250 discount. 928-910-3599. Reach out to Ashley and get ready for a life-changing experience.
Now, when we did this hybrid approach and we did the rapid appliance, there is a portion when we used to use row, and then we bought the printer. And then we would just print both the rapid appliance and the teeth at our own clinic. So on the day of surgery, all you're doing is you're getting all your scans, you're getting the pickups, and then we're going to assign all this data to the designer. And we did this back, I think this was about 2019 we were doing this. Now at this point in time, this is when we're like, well, why don't we just like deliver it the next day so we can print it? So we started to do that. So we came into the next day, we would print it overnight time. Then the patient would come in. And then we would send the patient at home in comfort caps. So when they came in the next day, we would put temp cylinders on the implants and we'd pick up the implants. We would pick up the teeth on the patient at that visit.
And so the benefit of doing it that way is you don't have blood from a post-surgical site. Let's say, it's a long surgery, the patient has high blood pressure, they're on anticoagulants, whatever the case may be. They just might be bleeding and you can't do your pickup as effectively. So if they come back in the next day, it's sometimes easier to do it then, but you have to take in consideration like the patient comfort. So sometimes they can take some Norco before they come in. You can have them take Norco and ibuprofen. There's products called Exparel where you can get them numb and they stay numb for 48 hours to 72 hours. There's a lot of different ways to do your conversions next day and make your life easier. And as long as you present it to the patient where like, hey, this is how 99% of people do it and everything is fine, patients don't have a problem doing this next day. They understand it's a process. Marketing with teeth in a day doesn't mean you have to do the teeth in a day. Sometimes you're tired after the surgery and you're tired after suturing and you just want to like be the best version of yourself for the next day. And you can break these cases out so you don't have to burn yourself out in the beginning.
Mm-hmm. So this is what it kind of looks like. This material, I don't even remember what we printed this out of a long time ago. But oh no, this one is actually milled. I think we milled this at that time. So the designer returns the teeth in a file that we mill or we print, and they're going to have holes that they already in their software added holes into the prosthetic. So all you do is print it, and then you seat it over the top of the patient's temp cylinders, and you just put a little bit of cement around just those temp cylinders individually. So this would be what it looks like right after you pick it up, before we do any of the finishing.
And
process.
Keep in mind, when he said cement, he like literally made us a resin, full 100% resin cement that you bond and light cure. Which one was it? It was like that dual cure universal.
Duo Link. Visco Duo Link was the one that it was.
And then also, if you go back to the prosthetic, if you could please, the design here, you see how this is a design that's going to trap food. So you need to make sure, and we'll show you different examples of new prosthetic designs, but this is a design in a prosthetic where if you deliver this as a temporary, you're probably going to have the patient pack food underneath it. And so you need to place your implants probably a little deeper, maybe do a little bit more bone reduction. So you have more of an emergence profile and a flatter intaglio surface present, so the patients can cleanse it better. So then what I guarantee happened here is in the final, it was redesigned and the soft tissue was recontoured in order to get a more hygienic type of prosthetic created. But it's easy to do the surgery. It's hard to manage the prosthetics. And always remember that once you get the surgery done, the prosthetic part is the challenging part because that's when you're doing like the 20-year work for these patients. So there's always ways to improve.
Mm-hmm. And I always put this one, put this one in the side because it's so controversial. Because this is like this is one of our first ones, so that was kind of a nice picture to show like what we started with like 4 or 5 years ago. Because there's a big learning curve. It's like we know that this would trap food, but our computer designer at the time doesn't understand that, right? There's a big learning curve here. Like the computer designer has no idea what the emergence is supposed to look like or how much tissue impingement they're supposed to put from the prosthetic onto the tissue from the scan, right? There's a big learning curve that happened over the past few years here in this space.
Yeah, and one of the benefits of us kind of beta testing a lot of these materials and techniques and approaches is if you guys contact the designers that we recommend, you can just say, hey, do it how Dr. Brisky and Dr. Dune want it on their lab scripts. And it just saves a whole lot of that communicational barrier. So we'll make a couple of recommendations. And then obviously, if you're watching this, don't go tell all your friends about the recommendations because then we blow up the lab and then they can't handle the volume. So if you take the time to watch this, make sure you just kind of play a couple of these recommendations close to the chest as well.
The hug of death.
It really is true. We've killed like 4 designers. We used to have really good designers back in the day, and they called and their quality went down. And so, yeah, we will recommend a few. I mean, right now it's Rowe, but a new one. No, I know, but a new one is Power Dental. Power Dental is knocking it out of the park. It doesn't mean Rowe is doing bad work by any stretch of the imagination. It's just I'm really thrilled with Power Dental's work. As we sit here today, in December or almost December of 2023, if you're watching this in the future.
Yeah, that's what we're using now because they have a huge team. They have a team of like 40 or 50 designers now. And they can do design turnarounds within 45 minutes, which is really cool. Yeah. So that's why we're advising people to use some of them. So when we did this way, when you're doing a milled PMMA with the holes already fabricated in it or the printed, then there's no acrylic, which is nice. So you could just squirt some of the Visco Duo-Link cement around the temp cylinder. But always make sure you do a metal primer on the temp cylinder. So like a Z prime. A Z prime from Visco would be what that would be. But also a PMMA primer. So if you're doing this type of technique, I would still advise you to buy a PMMA primer, and where one would be from is an Accent. An Accent sells a PMMA primer or printed resin primer that will actually prime it enough to where the cement will stick to it. Because last thing you want still is for everything to become loose or it doesn't pick up a few days after you picked it up.
And if you have 6 implants up there, sometimes you can't pick up all 6 at the same time.
Sometimes it's like the parallelism that occurs is you can only pick up 2 or 3 at a time, or you have to make the access holes larger to then seat it over your temps, and then you're weakening the structure and introducing more variables. So sometimes just know if you have 6, even 4 implants, you might only pick up 2 at a time, and take your time to do this step right, because this is where you're getting passivity. This is where you're going to really secure those temp cylinders in, and it saves you broken prosthetics with these patients in the future. All right, actually go to that. So that's how you pour it up in stone. If you go to the stone one, so that's literally you can send that to a lab, and the lab can scan that with their own photogrammetry units or their own tabletop scanners, and then they can send you files back for you to 3D print. There's also labs that are popping up everywhere that own their own like iCams, so you can contact the lab and you can pre-schedule your surgery in certain states and cities. And they'll come to your office and they'll scan the patient's chair side with you. And then you can do a next day delivery with direct to multi-unit without ever having to buy the $40,000, $50,000 photogrammetry units and things like that. So there's a lot of options you have in this hybrid model. And based on where you are geographically, you may have better options than other people who are a little bit more rural too. Now, everything costs money, but you got the options nonetheless.
But if you have just a Medit or iTero scanner, you could forego this step, right? And submit a scan to the designer, correct?
So, okay, this is a good point to touch base on. So there's going to be what's the global accuracy of what can occur here, and an intraoral scanner in very few people's hands will be accurate every single time.
Okay.
It's almost like a mathematic impossibility that you have accuracy on just an intraoral scan only. So what you may find, and what I found in the past, was out of these 6 implants, I'd get 4 to engage, and then 2 I'd have to chair side pickup. Or the resin can stretch a little bit. Well, zirconia is not going to stretch, so you're not going to have a passive fit on your zirconia. So maybe you temporarily get away with it in a temp, but then you got to pay the bill when it comes to the zirconias. So to some degree, yes, it can be accurate. Is it going to be 100% accurate? I'd say for the vast majority of the population, the answer is going to be no. You need additional steps in there to verify accuracy.
What we used to do is when we put what we would do with a Medit, we'd take a multi-unit scan body, right? So you put a scan body on a multi-unit. You can scan that around the entire arch, and then you're going to send that to the designer. And then they're going to make you a printed or milled, printed or PMMA that has a hole cut in it, but also they can make you one that they did a screw retain. But what we used to do is we used to print both. We would print one that was screw retained and one that had holes in it. And 80% of the time it would fit, but 20% of the time it wouldn't. So on the 20% of the time that it wouldn't, we would put the temp cylinders on and then pick it up. So that way the patient still will leave with something, because you never want to think it's going to work all the time, especially when the patient paid $25K. So that's when we would print both. We would print one with a hole and one with it screw retained. And if it didn't fit, we have a backup solution where we can go towards picking up the temp cylinders.
Cool. Yeah. Thanks for clarification, guys.
Yeah, of course.
So yeah, it's always important, like in the airline industries, they'll have 3 power sources and 3 navigation systems and all that stuff. Build in redundancies to these complex procedures to leave yourself out, just in case anything does go wrong or your printer misfires or something breaks or you drop it, always have a backup.
Mm-hmm. Yeah. Cool.
That's all I got for this time.
Okay. So how much time do we have left? We got quite a bit of time left.
About 15 minutes.
Yeah. Mark, what direction do you think we should take this in terms of prosthetics? Because we can go into photogrammetry and whatnot, but we kind of broke that out into a separate lecture because it's such a meaty topic. Yeah. A lot of people want to get into the space and to do this for, and they don't know if they want to do full arch right off the bat, so they don't want to invest $100,000 to get started. Mm-hmm. What would you recommend to people trying to get into the game? But obviously we teach profitability and how to run a safe business. Mm-hmm. So I want to make sure we address those points too.
Yeah. So I think that to keep it clean, we leave the formal lecture and slides to the analog/combo, technique that you guys have talked about, but it would be helpful without slides just to talk through the digital workflow, because I do know that when people see it for the very first time and they've been doing analog for a period of time or even a combination technique, it's a little mysterious. So if we could talk about exactly how you guys do it with the TADs and the actual photogrammetry and all of that, just quickly from a high view, and that'll be a nice teaser to the full length lecture that we're going to give next time.
That sounds good.
And then just real quick before we get to that, Dr. David Epstein has a question on what's the best way to train your assistants on printing. And there's a lot of resources out there. So it's finding a colleague's office that has the skill set you're looking at. Most of us, the hope is that most of us want to help each other. And so if anyone locally in my area, or even, David, if you want to send someone to my office, wanted to have their assistant get reps, that's a good way, is just to go to an office, pick their brain. And anytime there's a QC or quality control issue, they call the person who trained them and just say, hey, here's what happened. And then a person with experience will say, oh yeah, well, that's because X, Y, and Z occurred. 2, labs like Power Dental or Rowe, or even your Neodent reps that understand the digital workspace, they can also coach you through, or Voxel, they can coach you through what's happening because they have a really profound understanding of it. And there's labs that train my team. So at the end of the day, if you're going to buy some equipment from them, then they're invested in you being good at using them because they also sell you the resin. So there's a financial benefit to them training your team. So I would definitely delegate. I don't do any of the printing or any of this stuff. And I never have. And it's just my team was trained by other people and now they pay that forward.
So I took a slightly different route than that. So I believe, my personal belief on this matter is, if you think that this is a really freaking cool ass thing to do and you're doing this in your own practice, your DA is going to be like, well, I want to do it too. So I was doing all the printing myself at my startup, and now everyone wants to do it. It's like, oh, Dr. Brisky's doing it. This is so cool. I want to learn it also. And David, I feel like we know each other really well now. And I think part of the question for best way to training your assistants is an easy, okay, what can you buy or things you can do in your practice to eliminate the amount of time, that happens in the printing world. And I remember seeing your comment the other day on DSN. You're asking about like a frozen printer. I remember seeing that. And I actually have a frozen printer at my practice, and I used it, but I got a lot of misprints, and it was a big learning curve. So that became annoying for me. So I ended up buying a printer like a P20, something that just doesn't break and never misfires. And for me, it's been so easy because the DAs, there's really no learning curve. You teach them how to enter it onto a computer, and you teach them how to put the tray inside the printer and close it, and you press the start button. That's literally how easy it is. So the learning curve is so small, because your workflow is so precise and your machine runs so well. So nowadays I've kind of completely rethought about how, what I buy, the amount of time I spend on something. So now I'm more of a fan of buying a machine that just doesn't break and will always function and will always print. And the learning curve is way smaller. And at that point, the parts that the DAs need to be trained on, for the printing is really just how to put the STL file into the computer, to nest it. That's a very easy process to do. Then they just run over, they press print, and then from that point, they're going to wash and cure the prosthetic. And there's very minor steps that I'd be happy to share with your assistants to do those steps. But I always encourage people to eliminate steps where you can.
Yeah, I think that's a good topic to just pull the thread on a little bit. There are things that you want to save money on, and there's things that you want to invest in that will save you money in terms of time and headaches and reputation with patients. So like, don't get a knockoff, implant brand for $49 for the implant, right? Like a Neodent implant is a very affordable implant. I'm not saying go buy Straumann implants or Nobel implants at $400 a pop, but I'm saying, you get a Neodent one for like $150 a pop, or whatever your rep can get you in terms of price. Mm-hmm. Printer wise, don't go cheap, or don't go with those like makeshift printers. But get a nice printer. But when you do your PRF, get a PRF box off eBay. Get a few things off eBay that, are just reused in a way where it has no effect on long-term, results. So in terms of what we can teach people on how to save on supplies and techniques and materials, all of that savings will add up to help you afford the printer that you really want, so then you can just delegate it to your team.
And some people love to deal with the printers, right? Some people's personality, hey, I'm buying this machine because I want to mess with it, or I want to learn on it, or what are some cool things I can do with it? That's not my personality. I want to buy something that's just going to work. And if it doesn't work, I'm going to get really pissed off. So I think it's just knowing your own personality, too. Like if you want to play it, you can get a knockoff printer to work just fine. You definitely 100% can. It's going to be more work though, and a little bit more maintenance. And you have to ask your question yourself if you're okay with that extra time, I'd say.
So let's hop into just a quick overview of the photogrammetry workflow and what that's going to look like. And then of course, we're going to cover it, way more in depth and all the nuances in the next episode we do.
Right. So when we were doing the hybrid approach, right, when we made a denture, we were getting the tooth position. When we did the pickup portion or when we got a scan of the arch, we were getting the soft tissue. And there's two major records you need in full arch. There's only two things you need to think about, implant and soft tissue. And when you combine those two things, you get an arch, because now you know where the teeth will be up until fitting against the gingiva, but you also know the exact location of all the implants and how they diverge. And then can you print something that not only accounts for the implant position, but also accounts for the soft tissue, right? That's what you're going for. So there's two things you have to think about. When you're getting soft tissue, you can get it with an impression, right? You can do a Solgernet or VPS, whatever, or you can get an intraoral scan. Intraoral scanners now, I would argue, best one on the market for sure is Trios. I think Dude and I would definitely both agree on that. That I think is the new kind of standard of care. The Medits just don't work as well. They feel like a little toy compared to Trios when you start using one, I'd say. But then an iTero it'll work, but it's going to be a lot slower. So again, I say if you're just investing in a scanner, I would still go with the Trios.
Yeah, and here's the thing, like, I own 2
Metids and 2 iteros, and I cannot get my Metids to work consistently on surgical dates. So I have to take an impression and then scan the impression outside the mouth. So I'm switching over to a Trios because from a surgical perspective, it is superior. If you're just doing crown and bridge, yeah, I don't know. I just whatever works best in your hands. But if it's surgery based, and that's obviously the topic that we're covering, the Trios is going to be, one of the best on the market, if not the best on the market for intraoral scanners.
Now, even a soft tissue scan can be reliable or cannot be reliable. If you get an impression with Silginate and then you scan it with an intraoral scanner, that tends to be slightly more accurate for the mandibular arch than if you were to just use an intraoral scanner. Because as you're going on an intraoral scanner, you're going across the arch, you're creating a lot of double images. So I've found over the years, things tend to fit slightly better, maybe like 10%, if I was to take an impression on the lower arch and then scan it outside of the mouth. Or if you have a lab scanner, like a desktop scanner, you could throw the impression inside the desktop scanner, and that will have the most accurate result, right? We don't need it to be 100%. We still need to be functional. So you can argue that it is good enough to get an intraoral scanner for a soft tissue impression. But if you want the absolute best result, you have to buy data, take an impression, and throw it in a desktop scanner to get something that's 100% accurate.
And from a functional perspective, I did that for a couple of months, and then I just returned my desktop scanner. It just didn't move the needle enough for the private practice as well as the surgical arm of the practice to have that like 10 to 12 to more $1,000 investment in just that one thing. So I'm from the vantage point of like, I didn't like it, but from a knowledge perspective, intellectually, Dr. Brisky is spot on with, how you can use it.
So if you have a soft tissue, right, you know where the soft tissue is, you still need to know the implant position. So you can either scan it with scan flags on your multi-units and risk having double images, or if you're really good and you're using more techniques like, how like Jonathan Abenine teaches about how you can splint the multi-units with like a piece of ortho wire, or you
composite,
put flowable.
Yeah.
Yeah. Composite flowable, like an S. You paint an S on composite flowable between each multi-unit. And what you're doing is you're just keeping your scanner from getting distracted. Is all you're doing. You're keeping your scanner focused on one point of data where it's not going to get as many double images, right? As many. So if you're doing those techniques, I think that in terms of scanning, that will work for a temporary. I would still argue that would not work for a final. That's not 100% passive still. It's good enough to put a temporary on, but it's not good enough for a final, especially to risk breakages later down the road with expensive lab bills. Mm-hmm. So how do you make something that will last forever, right? Well, you have to get the exact implant position. And to get the exact implant position, you can either do what we did back in the day, where you take an impression and you pour it up, right? Like a stone model, and then you'll send that to the lab. And the lab will have the model in their hands because they know it's passive because you sectioned and you luted you sectioned and luted it yourself. That's passive. An easier technique is photogrammetry, right? Photogrammetry, I think most of us know what this is now, where it's a technique where you're scanning the exact implant position. So if you have a scanner, it scans the implants and it builds a computer data set that tells the lab exact geolocation and angulation of every single implant in the mouth. So you'll get a 100% passive fit. Now that's a really long conversation into photogrammetry still, like which ones to buy, which are accurate, which are not, and our opinions on that. But now if you're doing photogrammetry, very accurate. If you use an intraoral scanner, not so much, more difficult to get something that's reliable. So a third one would be something like OptiSplint. Now OptiSplint is just a piece of metal or a jig, and you're going to put it on your multi-unit, and you're going to lute it together with cement, right? Kind of like how we were doing before with Rapid Appliance. The attractiveness of the of the OptiSplint is just its ease of use, right? They took an idea and they ran with it. And they made an appliance that sits on the multi-units and made it easier for us to lute it together without getting error in our data in terms of how much flexure we get and making it more rigid. So it's a rigid piece that you can section and lute it together, basically. And with that, to get the implant position still, you still have to either scan it or, well, how do you scan it? Like if you scan it, you're going to introduce error. So then the argument still comes, well, maybe I should buy a desktop scanner if I'm using OptiSplint to have a 100% passive fit, right? So there's so much to go into this.
And here's the thing. It's sometimes dogma in terms of what's the best, because there's another company called Instarisa that is a facial scanner, and they have their own technique on getting implant location. And Art Morales and his team are awesome. So here's the thing: is like, do the research, kind of figure out what works best in your hands, and do the math. Like, okay, do I want to spend $12,000 to $15,000 on a desktop scanner, and then $500 per case or $400 per case on OptiSplint, or do I want to go with the Micron mapper and just pay $27,000 there, but get photogrammetry there? Or do I want to go with iCam, which I think is the more superior of all the photogrammetry units currently today? But that's, again, December of 23. And I think right around the corner with all the new people coming into the photogrammetry space, if you wait 6 months to a year, the whole industry is going to be changing and the price reductions are going to come. So sometimes patience will be the virtue over here, and it will maybe pay off to have OptiSplint and a Trios up and until we see price reductions in photogrammetry. So it's something to consider for sure. But if you're buying a scanner and you absolutely 100% need an intraoral scanner, and it does behoove you to do that because it works in your private practice nonetheless for Crown and Bridge, I would go with the Trios all day long, and we can unequivocally say that right now.
Awesome.
So, Mark, I hope we're not confusing people right now.
No, I mean,
it's just a long conversation.
No, it is a very long conversation, but I do think that it's worth, just this high overview to understand why you're doing what you're doing in the digital workflow. It makes perfect sense the way you guys are explaining it. What happens is there's too many different options for and alternatives to each of these digital steps. That's when things get confusing and people kind of lose their way a little bit. That's the benefit
of these hands-on courses, because then when you physically come and do the procedure or actually lute the OptiSplint to the implants, or actually pick up the iCam and do the scan, or pick up the Trios, or walk downstairs to the lab and see the whole design process and the 3D printers in action, that's when it all starts to come together. Because, from a knowledge-based perspective, like gathering knowledge through CE courses and through webinars and through podcasts is great, but you have to do the work on this specific procedure before like everything clicks. And then you have to go get repetition at home. And the repetition in the beginning is hard because you're not going to be as good on your first 20 cases as you are going to be on your next 20 cases. And it's just, you have to have the endurance and the stomach lining to get through the first 20, and to have your team train on the first 20, and then to lean on mentors and to lean on people you hear on webinars and podcasts, and who you go train with at CE events, and ask them questions, because they will, like, as our friend Alistair wants to say, or likes to say, they'll fold time for you. They will collapse time, where what took them 5 years to figure out, you can do in 3 months, because you're learning from all their wisdom. So this industry is moving towards implant dentistry. The market is moving towards reconstructive work done by generalists. And there's still a space for specialists always, because there's going to be complexity and revision cases coming up. So everyone is going to be doing this at some point. And it doesn't mean you have to do it. If you like to do veneers and crown and bridge and endo or anything else, that's totally cool. But if you are interested in implants, this industry is going to boom. And it already is booming, but the growth potential is parabolic here. So I'd encourage everyone to get started now so you can get your repetitions in now. So then you are in that kind of first wave of generalists who are implementing this on a major scale.
Mm-hmm. Or just figure out what you want to do with your career, right? I had no idea what I want to do with my career. So I dived deep into it, and I was like, oh, either I like this or I just really don't like it.
Yeah. Awesome. Well, that was great, you guys. Thank you so much. I'm excited to dig in deeper to the digital workflow at our very next meeting together with the three of us. You guys are just awesome and great instructors as far as being able to explain this stuff without confusing us too much. So really appreciate your time today. Thank you everybody that's here live and everybody that's going to watch this secondarily, the recording of this that's going to be posted for a period of time here in DSN. And until next time, we will see everybody. Dr. Taher Dune and Dr. Dan Brisky, thank you guys so much. All right, guys, this episode is being brought to you by the Dental Success Network. DSN is basically a three-legged stool of awesomeness and value. Leg number one, we're the most aggressive and largest buying group in all of dentistry, with some of the biggest vendors in our profession participating. Leg number two is a vibrant, active virtual community with over 1,200 active users sharing best practices on all things from clinical to practice ownership to business. And then, of course, leg number three, we have an online educational library made up of hundreds of hours of quality continuing education taught by some of the most well-respected thought leaders in dentistry. So if you're feeling stuck or just want to bring your career to the next level, go to dentalsuccessnetwork.com/free45 and we'll give you a free test drive for 45 days. That's dentalsuccessnetwork.com/free45. And that wraps it up for another episode of the Dentalpreneur podcast. Look forward to reconnecting on the next episode.
Thank you so much for joining us today on the Dentalpreneur podcast. Check out TrueDentalSuccess.com for full recaps of every show, a schedule of our live events, free video tutorials, and a whole host of practice building resources.